Okay, so let's talk about pulmonary embolism, which is a blood clot that has lodged in one of the uh, pulmonary artery vessels in the lung. Okay, by far the most common cause of a pulmonary embolism is having a deep vein thrombosis in your leg. So any risk factor for a DVT will also be a risk factor for a PE, because the DVT that's in the leg, a piece of the clot breaks off and travels up the inferior vena cava to the right side of your heart, and then the right ventricle pumps the clot into your lung, resulting in a pulmonary embolus. So what does that cause? Well, that's going to lead to a VQ mismatch, meaning you'll have a portion of your lung that is ventilating, but there's no blood flow going to that part of the lung. Okay, so there's ventilation, but there's no perfusion, and that is a problem, and we'll come to that. So any risk factor for a PE will be the same for a DVT. So let's look at some risk factors. So a fractured leg, right? So a femur fracture, well, the veins are very close to the bone. So if you fracture your femur, you could injure the vein that results in a DVT. Immobility, so someone who's sick in bed or in hospital and immobile, that results in very slow blood flow in the veins and an increased chance of leading to a clot in the vein. Surgery, so post-operative period is a risk factor because you're immobile, right? Cancer, so cancers in basically any part of the body release a lot of factors into the bloodstream, and one of the things they do is thicken the blood, right? So the body is trying to fight this cancer. It's producing some inflammation. It's producing more proteins from the liver, and that can result in thickened blood, resulting in a DVT. The use of estrogens, such as in the birth control pill, is definitely a risk factor for a DVT or a PE. Okay, so women that are on birth control pills have a slightly increased chance of developing a DVT or a PE. It's still very small, but it's increased compared to not taking it at all. Pregnancy is a risk factor because someone who's pregnant, there's more pressure on the veins that are trying to flow back from the legs, so that the veins are being compressed, and it slows down the blood flow in the veins that can result in a DVT. And on top of that, when you're pregnant, you're releasing lots of estrogen. Okay. Smoking is a risk factor because of the chemicals in the smoke thicken the blood. Okay. And that can, and they also damage the blood vessels. So smokers are at risk for a DVT, and that's partly why a smoker really shouldn't be taking the birth control pill, because now you have two risk factors. Obesity. So with obesity, there's kinking or blockage of the veins behind the knees, at the hips, where the veins travel, but you can flex your hips, right? So someone who is obese can have blockage of those areas and kinking of the veins, resulting in slower blood flow, and a risk factor is for DVT, and of course for a PE as well. So when we talk about a term called Virchow's triad, it's really a term we use for the risk factors for developing a DVT. So if you have any kind of endothelial damage, meaning damage to the vein, plus any kind of hypercoagulable state, such as being a smoker, uh, having cancer, being immobile. So immobile is actually going to be under stasis. So any hypercoagulable state is going to increase your chance of developing a DVT. Stasis, that just means you're not mobile, right? So there's going to be stasis of blood, slowing down of blood. So Virchow's triad is really, here are all the different risk factors, but in a pathological description. Anything that injures the vein, anything that leads to a hypercoagulable state, or anything that slows down blood flow. Those three things, okay? So I'll give you an example of sitting in a car for a 10-hour drive. Well, you're sitting in the car, say you're a smoker and you're on the birth control pill. You don't have any endothelial damage, but you have a hypercoagulable state because you're a smoker and you're on a birth control pill, and now you're sitting in the car for 10 hours, so you have stasis of blood, and that's going to increase your chance of developing a DVT. Okay, that's why long-haul flights are a risk factor for DVT, because you're really not moving for many hours, and at the same time your legs are flexed at the hip and flexed at the knees, which is causing kinking and blockage of the veins a bit. Okay, so what are the symptoms of a DVT? Well, typically you have swelling of one leg only, not both legs, right? Swelling of both legs is usually something more systemic, like congestive heart failure or a renal problem, such as nephrotic syndrome. So it's unilateral leg swelling, because the blood clot is really only affecting one leg typically, and it's blocking the veins, the deep veins in one leg. So leg swelling, leg tenderness, and leg redness, because there's blockage of the blood flow that can return back to the heart. Okay, so having a DVT is anything that can lead to a DVT is a risk factor for developing a PE. What are the symptoms of a PE? Well, sudden onset of shortness of breath, right? You just blocked up a portion of the pulmonary artery that's going to one of your lungs. Coughing up blood, okay, because the blood vessels in that area have now suddenly become blocked, and the blood vessels are going to leak into the alveoli, right, because they're dying, and you're going to cough up blood. Pleuritic chest pain. So when you block an artery in your lung, anything that was being fed by that artery, such as it was going to alveoli, but it was also likely feeding the pleura, which is that very sensitive lining around your lungs. So now when you take a breath, you're stretching that pleura, and it really hurts. It's very painful. Okay, so taking a big breath and then complaining of chest pain is what we call pleuritic chest pain. Okay, and finally, if the blood clot is large enough and it just blocks up a huge portion of the pulmonary artery that's feeding the lungs, well, now you've blocked up the blood flow that can return to the left side of the heart. So there's very little blood flow to the left side of the heart, meaning there's very little blood flow that's going into the aorta, that's being pumped into the aorta, and your blood pressure drops, and you have syncope, you collapse. So syncope means a brief episode of loss of consciousness. Okay, and so think of all the mechanisms of how these symptoms occur, and then you'll remember them better, right? So the shortness of breath, because you have a VQ mismatch due to the blocked perfusion, coughing up blood, pleuritic chest pain, meaning when I take a deep breath, it's really painful in a part of my chest wall, and suddenly collapsing due to hypotension. Okay, so onto a new subject, obstructive sleep apnea. So sleep apnea is a relatively common condition as well. And when we're talking about obstructive sleep apnea, we're referring to the tissues in the back of your throat and in your neck that while you're sleeping, you become much more relaxed. And the tissues occlude the airway, and you have periods through the night where you're not breathing, called apnea, right? So now there's also a condition called central sleep apnea, where the brainstem forgets to send signals to the respiratory muscles, and you have periods of apnea, but it's not because anything's obstructed. So we're going to talk about obstructive sleep apnea. So the pharyngeal and laryngeal muscles relax while we're sleeping, and that causes the inability of air to flow through the obstruction, and you stop breathing while you're asleep, and that causes hypoxemia. Okay, so you're sleeping, your tissues are causing airway obstruction, and now that leads to hypoxia in your bloodstream. And then of course, as you get hypoxic, your body wakes you up. Okay, it senses that there's a problem with low oxygen, and it activates you and wakes you up repeatedly through the night, and then you fall asleep again. You get more obstructive sleep apnea, you wake up. So you can imagine that with waking up multiple times through the night with this, you have daytime fatigue and you're very sleepy. Okay, so this can be a big issue for patients that are truck drivers. So they need to have daytime alertness, and if they're falling asleep at the wheel, that's going to result in a disaster. Or you can imagine a surgeon who has sleep apnea and can't concentrate on the surgery through the day, because basically his nights are periods of waking up, falling back asleep, waking up, falling back asleep, due to obstructive sleep apnea. Okay, so what are the risk factors for having sleep apnea or obstructive sleep apnea? Well, being obese, right? Being obese means you also have extra tissue in your neck and in your pharyngeal and laryngeal spaces. And so when you fall asleep, they occlude more easily. Males are much more common than females. Alcohol or any kind of a sedative, such as a benzodiazepine, will result in more relaxation of the muscles and more sleep apnea. Smoking is a risk factor for obstructive sleep apnea. Say you have a cold or you're congested. That is a risk factor for sleep apnea, because now your pharynx and your larynx is filled with sputum and congestion, and that can aggravate sleep apnea. Okay, so when you think of sleep apnea, think of obesity, being a smoker, alcohol consumption that's relaxed you more, or the use of benzodiazepines. And this can result in what's called pulmonary hypertension. So what happens is you have episodes through the night where you're obstructing. Okay, so now you're not ventilating for those episodes. You're actually not breathing, right? That's why we call it apnea. And you can go on for many seconds, so 10 or 20 or 30 seconds of not breathing. until you finally wake up. So the alveoli are not getting the oxygen, and that's going to result in hypoxemia in the bloodstream. Okay. So why does that make your right heart fail? Well, if your alveoli aren't getting proper oxygen to give to the capillaries vasoconstrict. So the capillaries have this ability in your lungs to decide to vasoconstrict to all the alveoli that aren't providing oxygen. And that allows them to funnel the blood to other parts of your lung that are being ventilated and oxygenated. Okay, so if all of your lungs are not being oxygenated because the sleep apnea is really blocking your upper airway, right? Your pharynx and your larynx. Well, all of your alveoli are hypoxic. You're going to get pulmonary vasoconstriction, and when you vasoconstrict all the little arterioles, now the pressure in the pulmonary artery goes up because the blood isn't able to flow through all these narrowed blood vessels, and the poor right ventricle has to pump against higher and higher pressures in the pulmonary artery, leading to right heart failure. Finally, the right ventricle says, I just can't pump against these high blood pressures. I'm going to fail. Okay, and that's called cor pulmonale. So cor pulmonale is basically the same as right heart failure, and it can be due to COPD because a lot of alveoli are destroyed, or hypoxic, low in oxygen, and the blood vessels vasoconstrict. So the most common cause of right heart failure is actually COPD, or one of the most common causes. In actual fact, the most common cause of right heart failure is left heart failure, but we'll talk about that later. Just understand the concept of how you develop right heart failure, called cor pulmonale, in the setting of sleep apnea. Okay? We'll talk about this concept more when we get to cardiology. Okay, so let's look at tuberculosis. So tuberculosis is primarily a lung infection. It can spread to other parts of the body, such as the kidneys, the adrenal glands, the lymph nodes, but primarily it's a lung infection because you need to inhale the droplets that are infected with mycobacteria. Okay, so mycobacteria is really referring to tuberculosis. The transmission occurs through airborne droplets, so sneezing, coughing, being in close contact with someone who has active tuberculosis, meaning they're coughing these infected droplets into the air. And what happens is the mycobacterium sets up infections within the lung. And these infiltrates, where the infection is, we call it an infiltrate, will grow and grow and grow, and then start to form cavities. So it's destroying the lung and forming cavities of infection. And finally, the body tries to wall off the entire infection with granulation tissue. It tries to fibrose off the infection and block it from getting to other parts of the body. So who gets tuberculosis? Well, by far the most common are immunocompromised patients and patients that are living in densely populated conditions. So that would include patients that are in prison, so they're incarcerated, patients that live in shelters, so very dense populations are a risk factor for tuberculosis. Okay. What are the symptoms of tuberculosis? Well, it's an ongoing cough for weeks to months. Often you have a bloody sputum because all of these cavities are also bleeding. So you're coughing up blood. You have significant weight loss because your body is using so much energy to try and attack this infection and wall it off that you're losing weight. You often have profound fatigue, ongoing chills and sweats, often at night. Okay, and of course fever since it's an infection. Okay, so it's a chronic infection, and when we talk about the treatment, you'll see that it's going to take 3 or 4 different medications to treat tuberculosis at the same time, and they often need to take the medication for 9 to 12 months. Okay, so here's a question on tuberculosis in terms of how it's transmitted. So is it transmitted the fecal oral route? So that means typically that you've touched something with your hand and then you've touched your mouth. And tuberculosis doesn't spread that way. Contact with blood. So that would be more hepatitis B, hepatitis C, HIV, right? You don't need contact with blood to get tuberculosis. Contact with urine. No, that's not a way to acquire tuberculosis. Inhalation of infected droplets is definitely the answer, right? And then they set up these infiltrates within the lung. Okay, let's go on to the next topic and talk about a condition called pulmonary hypertension. And when we talk about pulmonary hypertension, just remember, all that means is high blood pressure in the pulmonary vessels, typically the pulmonary arteries and arterioles that are being pumped from the right ventricle. So the blood that goes from the right ventricle to all the arterioles and capillaries to the lungs. Okay, so primary or idiopathic is the same as just we don't know the cause, idiopathic. Primary pulmonary hypertension is usually a genetic disease with an unknown cause. Very difficult to treat, okay? And what happens is the blood vessels in the lungs begin to be destroyed and vasoconstricted, okay? So when you have blood vessels that are vasoconstricted, the poor right ventricle is now having to pump against high pressures because the blood has nowhere to go since these blood vessels are severely vasoconstricted or damaged in primary pulmonary hypertension, and you develop right heart failure finally, right? So pulmonary hypertension leads to right heart failure. So how do we try and treat this condition? Well, we try and use all kinds of medications to, well, first of all, many patients need oxygen, right? Because there's decreased perfusion from the alveoli to these blood vessels since they're so vasoconstricted. We try and use vasodilators to open up some of these blood vessels, such as calcium channel blockers. Those vasodilate the blood vessels. Okay, sildenafil or tadalafil, they're both the same. They're used for erectile dysfunction, but they lead to vasodilation. So they've been tried for this condition as well. So I wouldn't concentrate too much on the treatment. I would concentrate more on the concept of what happens with primary pulmonary hypertension, its destruction and vasoconstriction of blood vessels, which puts increased pressure in the pulmonary artery, which then leads to right heart failure, called cor pulmonale. There's really no cure for this. I mean, the only cure is a lung transplant, right? So organ transplantation. Secondary pulmonary hypertension. Okay, so what can cause high blood pressure in the pulmonary artery and all of its branches? Well, we spoke about COPD, right? So COPD leads to vasoconstriction of these blood vessels because there's less and less oxygen in these damaged alveoli from the emphysema. And the blood vessels are very smart. They vasoconstrict where there's no oxygen, but that results in elevated pulmonary artery pressures and in the end, right ventricle failure, okay, which is called cor pulmonale. What about a pulmonary embolus that's now blocked a major portion of the pulmonary artery? Well, that's going to lead to high pressures, right, and result in right heart failure. What about pulmonary fibrosis? So the alveoli are fibrosing. Well, there's no oxygen going to them. The capillaries are going to vasoconstrict, and there's going to be increased pressure in the pulmonary artery, again leading to right heart failure. What's the most common cause of right heart failure? Well, that's left heart failure. So when your left heart fails, it's not able to pump blood very well into the aorta. That backs up from the left ventricle to the left atrium, and then the fluid backs up into the pulmonary vessels. The pulmonary veins become filled and congested with blood, and then that finally backs up to the pulmonary artery system and puts increased pressure there, and that finally causes right heart failure, right? So it increases, so this backup of fluid from left heart failure causes pulmonary congestion or pulmonary hypertension in the arteries, and now the poor right ventricle can't pump, and now it fails. Okay, so the most common cause of right heart failure is left heart failure. Okay, so let's spend some time talking about asthma, which is a chronic, recurrent airway disorder, right? So it's where your bronchial tubes are very sensitive, and many triggers can cause them to bronchoconstrict. And on top of that, you'll have increased mucus production within the bronchial tubes. So we think this occurs partly from genetics and partly from the environment. So asthma often runs in families, and it runs in families that have other allergies as well, right? They may have skin allergies. They may have seasonal allergies. They may have eczema, which is an allergic skin condition. So now with asthma, really the underlying pathophysiology is the bronchial tubes are overreactive. So they bronchoconstrict very quickly and produce excessive secretions, which block the tiny bronchial tubes, making it difficult to breathe. So what are the symptoms of asthma? Well, when you have an asthma flare-up, you're going to be short of breath because you can't ventilate the air very well past these blocked tiny bronchial tubes that are bronchoconstricted and filled with mucus. You have expiratory wheezing, right? All that air that's trying to get out is whistling through all the mucus. You have coughing from the excessive mucus, and you're breathing fast since you're not getting the air in very well or out very well. Okay, so as I mentioned, it's often seen in patients that have other allergic conditions such as eczema. How do we treat it? Well, we treat the two parts of the asthma, right? So it's a bronchoconstriction issue. We use bronchodilators. It's an inflammatory condition where you make excessive secretions and mucus. We use anti-inflammatories such as corticosteroids. So inhaled corticosteroids are the mainstay treatment of asthma. Okay, we want to reduce the inflammation in the bronchial tubes. All right, so remember that it's a genetic part to asthma and an environmental part where patients are triggered by many things, certain foods, pollen, exercise. So you can have what's called exercise-induced asthma. So when you go to exert yourself, you get more wheezing. So I hope that helps you understand asthma a bit more. Again, bring up questions in tutorials if something's a bit confusing. Okay, let's just talk about this asthma attack here. So this boy is having a pretty severe asthma attack. You can see he's holding on to the bed, so he's splinting his arms. He's using his accessory muscles in his neck to try and help get air into the lungs. And you might notice that he's having a difficult time getting air out. Exhaling air is a major difficulty in patients that have an asthma attack. Okay, so this is all occurring from bronchoconstriction. So very, very narrow bronchial tubes that have now also filled with mucus. So the nebulizer that he's getting is a beta-2 agonist. And there's many of them. A very common one is albuterol. Another one is salbutamol. Okay, so they are beta-2 agonists. They try to bronchodilate. Now, in terms of the intravenous, what's he going to receive? He's definitely going to receive intravenous corticosteroids. Okay, so he's going to, we often use a medication called methylprednisolone, which is the IV form of oral prednisone. And what that does is try to reduce the inflammation and the mucus that's blocking up these airways. Okay? And we will use repeated doses of this nebulizer until we can bronchodilate the lungs. So if one mask doesn't do it, they'll get another one and another one until the bronchial tubes start to open up. If they don't open up, what's going to happen is he's going to run out of energy to continue breathing like that. And as a last resort, sometimes we have to intubate patients with asthma, but that ends up being a bad situation, because by just putting a tube into their trachea and putting them on a machine, we still can't force the air through all these narrowed bronchial tubes that are filled with mucus. So being intubated for an asthma attack is really the last thing that we'll do. But if it's that versus dying from not being able to breathe, then of course we'll intubate someone. Okay? Okay, so let's do this question together. Asthma is caused by sensitivity to specific allergens, severe respiratory tract infection, emotional distress, or fatigue. So the answer here is A, sensitivity to specific allergens. Now, that's not to say that you can't have an asthma attack without being exposed to any specific allergies. Remember, the underlying condition of asthma is bronchoconstriction and increased mucus production in the bronchial tubes. And that can be triggered by allergies in the environment. But it can also be triggered by just having a simple cold. So you're asthmatic, you get a cough and from a virus, and that triggers the asthma flare-up, and you end up being short of breath, wheezing, and you're in an asthma flare-up. Okay, so the answer is A, but just remember that anything can trigger an asthma attack in a particular person. And patients usually know what triggers their asthma attack. Sometimes it can even be walking by someone with perfume. And that's why many hospitals have gone scent-free, right? Because of patients with allergies and also with asthma. Now, emotional distress could trigger an asthma attack, but it's not typically the cause of the asthma, right? The cause of asthma is a genetic predisposition to bronchoconstriction and increased mucus production, and an environmental component that can trigger those two components to happen. Okay, I hope that helps.